All right. Good afternoon, everybody. Welcome to the November Telehealth Learning Collaborative. For those of you who have been around a while, you might remember me. Hi, I'm Katie, formerly Cook, but now Margison, and I am back in the telehealth space supporting AHI in the interim while we figure out what next steps are for the role that Jen Muthig left behind. But happy to step back in because this work was a passion of mine and really was my baby from 2016 through 2021. And many of you, I'm seeing a lot of familiar names and faces on today's call, so I'm happy to be back. So we have lots to cover today. Learning objectives. I put a couple things together. We're going to hear from some of our partners at the state first, but then I'm going to go into what's been happening in the telehealth space over the last year or two, talk about what's happening on the federal side of things. And we do have a colleague from CMS here as well who may be able to chime in. But I was telling my colleague Bob Hunt this morning I had to update the slide deck again because CMS did finalize the 2026 Medicare physician fee schedule. So I had to make some updates. So you are, as I understand it, getting the most up-to-date information today. So we're going to talk about some policy stuff, some state and federal things to consider, and what's going on in the telehealth space. So with that, we have a couple of speakers with us today. We're going to start with Casey, who's from the New York State Department of Health, and she's going to share a few telehealth updates from New York State Medicaid. So Casey, you should be able to unmute your line and you can take it away.
Okay, hi, good afternoon, everyone. Thanks for having me. You can hear me okay?
Yes.
Okay, great. As mentioned, my name is Casey DeBellis. I work in the New York State Medicaid program on telehealth policy. Thank you very much for having us so we can share a few brief updates. Next slide, please. Okay, so I'm thrilled to hear that someone from CMS is here, so they may be able to enlighten you more on this. But Medicare telehealth flexibilities, we received many questions about this over the past handful of months. So we wanted to use this opportunity to reiterate Medicaid's policy did not change, and it is distinct from Medicare's telehealth policy. The continuing resolution passed last week did extend those telehealth waivers or the flexibilities through the end of January. And we really encourage everybody in the provider community, members even, to stay informed of what's coming from CMS. They've issued a few announcements, provider notices with specific billing instructions regarding claims holds, what was going to happen during that lapse. So we will always do our best to assist if you come to us with questions, but we encourage you to go to CMS. Your MacPacs is a single source of truth on what's happening on the Medicare side. Next slide, please. If you aren't familiar, the department publishes a New York State Medicaid telehealth policy manual about every 6 months. We're in a January and July cycle, so we're prepping the updates now for the January edition. If you aren't familiar with this, it's a really fabulous resource. It's the best place for you to get all the information about what types of telehealth services that New York State Medicaid covers and the billing instructions for each of those. The manual is posted on our telehealth webpage linked here, or easy to find if you Google it. I also encourage you to subscribe to the Medicaid Update newsletter. We always publish an article in that newsletter announcing when we have a new version of the manual out. And we also use that newsletter for any announcements that we want to get out to you quicker than waiting for the manual. So you will see some information about important changes that may happen outside of January and July. So if you aren't already familiar and aren't subscribed, I strongly encourage you to do so. Next slide, please. Last, related to that, we did just issue a Medicaid update article in the September 2025 edition with an update to the school-based health center offsite billing guidance, essentially saying that a provider must be located at an SBHC for the service to be considered school-based and eligible to bill under those school-based specific rate codes. Those are not the same as the other PPS FQHC rate codes that you may be familiar with. If the provider is located at the operating facility and delivers services to the student via telehealth, they would bill according to the operator facility's guidance. Again, not those SBHC specific rate codes. So I encourage you to look at the billing grid that's in the Medicaid update that just went out for more detailed instructions about that. And we have been receiving questions about this as well. We may issue some sort of clarification or FAQ document, and we have been collaborating with the Division of Family Health, our colleagues in the Department of Health who oversee school-based health centers, so we can give you the best guidance about what you need to do. So I've included our email here. I encourage you to send any questions you may have about that to that email address. Next slide. Oh, and that's just our contact again. So please feel free to reach out anytime if you have any Medicaid telehealth questions, and we're happy to assist. Thank you for having me today.
Great. Thank you, Casey. I'll let you know if any questions come through. Great. So before we move on to the remaining slides, I wanted to open it up to Anna Kane from the Office of Mental Health if she had any updates she wanted to share. I know that there is an upcoming OMH training for telehealth providers, so I'd love to hear more about that. Anna, feel free to unmute your line.
Yes, can you hear me?
Yes.
Awesome, thanks. Yeah, no, the updates from our end are really mainly focusing around that training coming up on December 4th. I will be putting that on to use our summary of that, which folks got when they got the email to sign up. It's really a refresher webinar. So clarifying current telehealth standards, provider responsibilities, and documentation practices. We looked at data from our providers with regards to recertifications and areas that they were getting cited more frequently than others to really hone in on areas to spend a little bit more time on. But it will be no new information. So there's no changes to regulations, changes to standards of care. There's certainly opportunity to do so with the results and feedback from this webinar. So we will hope that providers did submit questions early, and we'll take advantage of the Q&A portion to see if and what movement is necessary. But that's all we've got on our end right now.
That's not necessarily a bad thing, right? I feel like things have died down so much that the crazy policy changes I remember during COVID, I'm glad that's behind us. So thank you, Anna. Last but not least, I'd love to open it up to Kelly Grace from OASAS if there are any updates on your end.
Hey everyone, yeah, we do have two important projects that we're working on over at OASIS. And so the first one is we've reviewed the recommendations that came from the Evidence-Based Benefit Review Advisory Council, which is EBRAC for short. And I'm not the lead on this. This is more in the area of our general counsel, but we're kind of collaborating with DOH to take a look at, basically the recommendation was that a telehealth only program for the use of medication for opioid use disorder should be covered by Medicaid. And so we're kind of working with DOH to look at what a potential oversight or regulation could look like. Will that be us regulating these entities? Will it be DOH? Most likely it will be us. And we'll kind of go from there with, follow-ups on what that ultimate recommendation will be from our end. And like I said, my general counsel is the main lead on this, but she does keep me in the loop. So any updates on that, we'll be able to share at a later date. And then another smaller project is that in the coming weeks, I'm going to be working with our doctors, our medical folks, to take a really close look at our current telehealth standards, which is basically our agency guidance document on telehealth. And I don't want to say that we're going to do a complete overhaul of the document, but we're going to really look at, best practice from a clinical aspect. And that'll be heavily led by the doctors. So Grace Hennessy and Pam Mund from my office. And I will pop my email into the chat so that you all have it in case there's any specific questions. But yeah, that's all the updates from my end.
Okay, both of those are exciting, I would say. We love a good like refresh on things, and
For sure.
great. And that EBRAC, is that the evidence-based? I missed the R and the A.
Yes, I can pop it into the chat too.
Okay,
So it's
great.
Evidence-Based Benefit Review Advisory Committee.
Got it.
Got it. I'll put it in the chat too. It's
Great. Thank you. If anybody
No
has
problem.
questions for them, please put them in the chat, but I'm going to continue forging ahead just because I have a lot that I want to cover. So we're going to get into it. So we're going to start with telehealth trends. And what slide is this? Okay. So in 2023 and 2024, approximately 25% of the Medicare fee-for-service Part B beneficiaries did receive a telehealth service. This is an overall decline from the pandemic high of 48% in 2020, and I pulled that right from the CMS website. And this tells me that telehealth is still a meaningful part of overall care delivery, but growth has slowed and even maybe plateauing. I've always said telehealth is a tool in the toolkit. It is not meant to necessarily replace or supplant care. So I'm not surprised to see this data. When we look at our own telehealth partnership data, we're seeing similar trends. Now, from Fair Health, which is a widely known organization, from April to June of this year, telehealth utilization remained higher in urban areas than in rural areas nationally. And I apologize, I'm recovering from a cold, so I struggle to talk sometimes. Also from April to June, the percentage increased overall in urban and rural areas. So you can see a slight increase here from 14.3 to 14.5% in urban areas, and then 7.4 to 7.5% in rural areas. And in April, May, and June of this year, the age groups that are 19 to 30 and 31 to 40 accounted for the largest shares of telehealth users, while children under 9 and adults over 65 had under 10%. To no one's surprise, the top diagnostic category was mental health, which was 63% of all telehealth patient claims in Q2 of this year. Okay, so some key innovation and care model shifts in the last year. Remote patient monitoring, which has really expanded beyond just chronic disease management to include post-operative care, maternity monitoring, and elderly care, and really includes now wearable data integration, which is devices like FDA and CE approved and connected via Bluetooth or 5G devices that integrate with cloud systems for real-time provider access, and systems that are used now by over 60% of hospitals in North America and even parts of the Middle East. So remote patient monitoring has really expanded beyond its initial use case. This evolution really does reduce readmissions and enables patient engagement in telehealth through that self-monitoring and behavioral feedback. AI in healthcare is also becoming critical to telemedicine. You're going to see virtual care systems become increasingly powered by things like predictive analytics to anticipate patient needs, natural language processing for automated documentation, and even AI chatbots, which I've been seeing for a while for triage, symptom assessment, and health education. So, for example, there are platforms both in the US and India now that employ machine learning models to aid in dermatological diagnosis during online consults. These technologies are enhancing clinical accuracy and allowing providers to manage higher volumes without compromising quality, or at least we hope. And through these AI-driven tools, these platforms are also delivering more personalized care journeys based on information in the EMR and also behavioral and genomic data, automated nudges to the patient for medication adherence and lifestyle interventions, and intelligent escalation to a clinician when there's deviations in the data that are detected. So this is going to be very interesting in the coming years to see what level of engagement there is with this and how beneficial is this to overall preventive care and reducing long-term healthcare costs. When we look at the market size of telehealth and telemedicine, an aging population does necessitate continuous monitoring of chronic conditions, which creates a growing demand for cost-effective solutions. And furthermore, there's a rising prevalence of chronic diseases such as diabetes and cardiovascular disease, so that further emphasizes the value of remote care. So we're seeing that the market is projected to grow from 94 billion last year to almost doubling to 180 billion by 2030, which is only a few years away. And again, those drivers are that aging population. There are some restraints, of course, around reimbursement, regulatory uncertainty, and then state-to-state licensing variation does complicate this. Now, we're going to shift into the impact of the government shutdown, which did end. But on October 1st, so I'm painting a little timeline here. So on October 1st, CMS issued guidance via their Medicare Learning Network, where legislative payment provisions would expire and Medicare administrative contractors, or MACs, are instructed to implement a temporary claims hold. Now, as of November 10th, which was a week ago, the Senate did pass a short-term funding bill that would extend Medicare's telehealth flexibilities post-public health emergency through January 30th of 2026. So there's more to this. Medicare policy for telehealth does remain somewhat in flux and claims are still delayed. So CMS instructed the MACs to hold most telehealth claims with dates of service on or after October 1st, unless they were clearly identified as mental or behavioral health. Now, CMS again had recommended, and probably I'm going to guess still recommends, providers that are issuing telehealth services now potentially not eligible for payment to consider providing an advance beneficiary notice of non-coverage to their payments. There are stakeholders like the American Telemedicine Association that are advocating that Congress include a retroactive reimbursement statement in any future funding fix to reassure providers that payments for services delivered during that gap will be provided. This temporary extension to January 30th still leaves telehealth policy in a state of flux, though, as it only maintains the flexibilities for a limited period, which, if you've been following this for a while, this has been the trend where the extension will be anywhere from like 30, 60, 90 days, sometimes 120, and then it will again get extended a certain amount of time, but nothing has become truly permanent. In the meantime, providers are continuing to navigate policy that is uncertain. There are delayed claims processing without the full Medicare telehealth waivers in effect. So what that means for you as providers, make sure you're checking diagnosis codes. Expect that claims could be returned. You may need to resubmit once guidance is and legislation is more firmed up. Okay, just looking through here. So CMS also noted that it has processed a small batch of other telehealth claims it identified as eligible for payment. But due to system limitations and the fact that some mental and behavioral health telehealth claims do not include this F01 to F99 diagnosis code, which is a very broad section of diagnosis codes for all things mental, behavioral, and neurological health. The system limitations have made it so that the system's unable to consistently identify all payable claims. So as a result, CMS is returning all claims that were held for dates of service between October 1st and November 10th, that waiver gap. Practitioners can resubmit any return claims that meet the statutory requirements. CMS has not specified yet whether or not this should be done right away, but suggests that when resubmitting eligible mental health telehealth claims, providers should ensure the claim includes a diagnosis code here on the slide in that range in order to be processed as payable under current policy. Providers who wish to resubmit claims for non-mental health telehealth services that don't meet the geographic or originating site restrictions would likely want to wait until Congress acts to reinstate the Medicare telehealth flexibilities that have expired on September 30th, 2025, likely through passage of a government funding bill. So FQHCs and rural health clinics always have a caveat, right? So CMS has updated their Medicare telehealth FAQ and made several important clarifications. One of the most significant is that FQHCs and RHCs may continue to bill G 2025 for services furnished through telecommunications technology, including audio only for non-behavioral health services through December 31st of 2026. So through the end of next year, these services are going to be paid using the PFS-based methodology, not the PPS or AIR. And CMS has clarified that G 2025 remains billable even after the September 30th waiver expiration, but some contractors are still holding these claims. So providers should be monitoring and appealing that as necessary. And just as a reminder, G 2025 is kind of just a bundled all-inclusive payment code that FQHCs and RHCs use to be reimbursed for medical telehealth services delivered to Medicare patients. Okay, so looking at in-person visit requirements when it comes to behavioral health. So the updated FAQ from CMS, as well as the finalized physician fee schedule, also addresses the in-person visit requirement tied to Medicare mental health telehealth services. CMS confirmed that the 6-month in-person requirement will apply only to patients who are newly established on or after October 1st, 2025, meaning existing patients will not need to retroactively meet that requirement to continue getting their care via telehealth. However, questions still remain regarding the 12-month subsequent in-person visit rule. CMS has not yet clarified whether the 12-month clock starts from the date of the policy's implementation, which was October 1st, or whether it is tied to each individual patient's last in-person visit. If Congress does not reinstate the broader waivers, as time goes by, this gap in guidance will become, I think, increasingly consequential for providers attempting to stay compliant. So let's talk about the finalized 2026 physician fee schedule for Medicare. So some major updates. CMS reduced the review process from 5 steps down to 3. And there are several new codes on this slide that have been added to the telehealth services list. The top 3 here, multiple family group psychotherapy, group behavioral counseling, and inherent visit to inpatient. I think those are very important ones, especially the group behavioral counseling. CMS did not add the new CPT telemedicine E&M codes, which is 98000 to 98015 to the telehealth services list. That's not on the slide, but I wanted to add that. Next up, let's see here. Oh, that's on the next slide. Sorry. Making sure I'm not forgetting anything here on this slide. Okay, we're going to go to the next slide. Sorry, my notes were a little out of order there for a second. Okay, so other flexibilities finalized. There has been permanent removal of frequency limits on subsequent inpatient visits, nursing facility visits, and critical care consults when furnished via telehealth. Next up is direct supervision via telehealth. So CMS finalized a permanent policy allowing direct supervision, this is a good thing, to be met via real-time two-way audio video. Audio only does not count. So teaching physician virtual presence flexibilities still revert largely to pre-public health emergency policy on January 1st, 2026, with rural exceptions maintained. So examples of services affected by this, it's pretty broad. So incident to services by nurses or medical assistants. So blood pressure checks, injections, simple wound care, med education, billed under a physician or mid-level, diagnostic tests. It does exclude services bundled into, again, a 10 or 90-day global surgical package. And there are those core statutory limits that's your geographic and originating site restrictions. Those still require congressional action at this point, and the temporary extension to January 30th, 2026 does not resolve that long-term telehealth cliff that we've all been facing. And then again, for rural health clinics and FQHCs, there has been that extension of G 2025 for the non-behavioral telehealth services through December 31st, 2026. Okay, so looking at, let's see, make sure. All right, so looking at Medicare telehealth policy, which again is still very much in flux. There's been a short-term extension through January 30th, 2026, but the long-term future is still dependent on broader funding and legislation. In the claims environment, the Medicare administrative contractors have held many telehealth claims with a date of service that is between October 1st and November 10th. And mental and behavioral telehealth claims have been given preferential treatment for processing, while others have been returned for resubmission. For FQHCs and RHCs, G 2025 is still billable. You're going to want to monitor and appeal that, though, as some Medicare administrative contractors are still treating these as part of the general telehealth claims freeze. So as a provider, what actions can you take? So audit any affected claims you have and ensure that the mental health diagnosis codes are captured where appropriate. And then decide whether to resubmit those non-mental health telehealth claims now versus waiting for congressional action. And then just keep an eye on CMS FAQs, the MLN bulletin, and the MAC bulletins. So in summary, telehealth remains a core component of healthcare delivery, and I think it's only going to continue to evolve and grow, especially as AI in healthcare evolves and grows. Federal policy is in a period of volatility. That claims hold for 5 weeks with delayed adjudication of claims and uncertainty around expiring waivers does continue to disrupt provider options or operations, and then of course patient access. The final Medicare physician fee schedule does offer some meaningful wins, though, with making permanent the virtual direct supervision, a simplified telehealth services list process, new telehealth eligible codes, and the extension of G 2025 for FQHCs and RHCs through the end of next year. But there are still key statutory telehealth flexibilities that depend on congressional action. The in-person requirements for telemental health beginning October 1st are a bit complex, but CMS did clarify the 6-month rule for new patients, leaving open questions, though, about the 12-month follow-up timeline. As a provider, you will want to navigate cross-state practice rules, evolving licensure compacts, which could be an entire webinar in and of itself, payer-specific enrollment requirements, and then ongoing claim system limitations. Of course, going forward, actively monitoring CMS updates, your MAC guidance, payer rules, and federal legislation is going to be essential to sustaining operational stability and optimizing your own telehealth program and access that you give to your patients, especially across rural and underserved communities. So with that, I'm happy to take any questions and do the best I can to answer them. Again, I'm stepping back into this space after some time away, so I had to do a lot of research to make sure that this information was accurate, which I hope it was. And I do see a question in here from Joanna about G0136, which is the SDOH screening, and that will remain. However, it will essentially be repurposed to only apply to nutritional and or physical screening. Does that match your reading as well? I did not get that deep into that specific code, Joanna, but I'm happy to look into that for you. So I will note your question and reply to you, and also put it into the meeting notes. I'm not sure. I just know that it was finalized for the 5 to 15-minute assessment and that it can be done via telehealth. Anybody else have questions or comments? Anything that I might not have covered? Oh, that's a good question. Okay, I just got a private question and it's for DOH. Is there any DOH guidance currently or on the horizon on the implementation of AI in healthcare specific to New York State? I'm going to say, Casey, if you know anything on that.
Yeah, hi everyone, this is Casey. I can speak honestly very little to this. I know there is a work group who is considering best practices for AI in the Medicaid space, and there very well may be other groups doing something similar more broadly or in specific programs. But I know Medicaid is thinking about how to do it responsibly, but I don't know what they have that we could share publicly at this time. I'm sorry to not be of more help.
No, that's okay. I think with AI, it's interesting, right? Because it's been around for several years, much longer, but in the limelight, especially in healthcare, for arguably the last 5 years, more prominently than ever. And I truly feel like if we don't start to better understand it and get on board with the options and opportunities, you could be left behind. And I say that very broadly, not in a judgmental way. This is just my observation as somebody that's been in the healthcare space a long time and tries to stay on the up and up of what AI is capable of. And even I don't even have a remote understanding of it, but I do use it in my day-to-day life for basic things. And in healthcare, I have been listening to presentations on this for a long time. And it is incredible what it's capable of. I've been to conferences where I've literally seen a telehealth interaction with an AI nurse and a patient, and that patient is never actually talking to a human being. They're just talking to an AI talking head that is able to triage and assess the individual and escalate if necessary to a clinician. Or it may just be a matter of, this is something you need to do, here's a script, what have you, or they're going to escalate it to a clinician to write a script. But it's equal parts concerning and exciting depending on how you look at it. Okay, anybody else have questions? I'm seeing some interaction in the chat about the SDOH screening. Okay, well, while we wrap things up, so this will be our last meeting in 2025. As you know, we meet every other month. So our next planned meeting, I'm just going to look at a calendar here for January. We might have to look at the date on that because I believe January 19th is a holiday. So it might end up being January 26th. So we will reconnect in the new year, and I will continue to keep an eye on CMS guidance, and if anything changes, I can send out a mass communication on that as those things come up so that you're in the know as well as it relates to your practice and what you do with telehealth. But otherwise, I'm happy to be back and really glad that you all, thank you, really glad that you are all able to get on today. Have a wonderful holiday season and we will be in touch. Thank you.